So today I'm going to discuss measles and the global epidemiology and opportunities for eradication. Firstly, I have geen disclosures as a speaker. So in this talk I'm going to give measles background as well as some epidemiology around measles. Also I'm going to just briefly touch on the actual definitions of elimination and eradication, as these are used interchangeably quite a lot. I'll then just discuss some of the global measles and rubella strategic plan goals and the successes and failures resulting from those, as well as challenges and the outlook for combating measles. So measles has been around for a very long time. So it was first described in the 10th century as more dreaded than smallpox. Smallpox is gone, but measles still is very much around. Measles is an RNA virus of the family Paramyxidae, and it is sustained through an unbroken chain of human-to-human transmission, and there's no known animal or environmental reservoir. Measles is an extremely contagious airborne disease, and it is the most infectious disease, and I think that's probably one of the reasons why it's very interesting. So the net reproduction number, or the R0 for measles, is between 12 and 18. And what that means that one infectious person in a susceptible environment where no one has had prior infection or immunization, this can lead to them infecting 18 other individuals. So it is a highly infectious disease, and that range of 12 to 18 can vary in certain outbreak settings, can be lower or higher. The symptoms of measles begin 7 to 14 days after a person is infected, and typically can kind of look like some type of flu-like symptoms with fever and cough. But in this time period, people actually are infectious before the rash appears, and that's one of the challenges in trying to combat measles, that they're infectious 4 days before and after rash onset. So this is again a challenge for measles because it's hard to know when someone is infectious. Another problem with measles is that it actually has quite a number of complications. So 30% of reported cases have complications, and they're most common in those aged below who get measles below 5 years or 20 plus years, or those who are malnourished. Pneumonia accounts for quite a high proportion of measles-related deaths, and diarrhea can cause severe dehydration and also require hospitalization. Otitis media is another complication which can lead to deafness, and encephalitis also is problematic and lead to hospitalizations. And then blindness is also a complication of measles. So quite a plethora of complications there. So it certainly is a disease that warrants eradication, really. So this is kind of a topic at the moment that's quite recent, where subacute sclerosing encephalitis, this is a progressive neurological disorder caused by persistent measles infection. And what happens is it's essentially measles remains dormant in the brain, and a couple of years following infection, it may manifest. And what happens is there's 3 stages of disease where people may notice behavioral changes in their children, followed by seizures and then coma. And it's fatal in each event. So that's something that people, were initially thought was quite an uncommon complication of measles, where it was thought to be at least 1 in 100,000 measles cases resulted in SSPE. However, a recent study in the US conducted by a group in California found that it's much higher. So children with measles below 5 years age have almost a 1 in 1,000 chance of developing SSPE. And amongst children who get measles below 12 months, there's an even more increased risk of developing SSPE. So it's a complication that is fatal in each event. So I think it is certainly a huge problem with measles infections. Thankfully, there is a very good measles vaccine. And the vaccine was developed in the 1960s, and it was a single component measles vaccine. And this, to this day, is still used in 44 of 47 African countries and 24 other countries, including Russia. So one of the reasons why it's used so widespread in these countries is because it's very, very cheap. And it's mostly subsidized by Gavi, which is the Global Alliance for Vaccines. And the vaccine can cost $1. It is slightly problematic then in terms of Rubella elimination, because then, it's a single component. But in the 1970s, measles was combined with mumps and rubella, and this vaccine is used in 90 countries, but mostly in Europe and North America. In the 2000s then, the Mmrv vaccine was developed, and this contains varicella. However, it's mostly used in the US, and it has slightly higher risk of febrile seizures, almost a doubling compared to the MMR vaccine. So I don't really see that this is going to be used widespread at the moment unless they make some more alterations to the vaccine. In terms of measles morbidity, before the vaccines, measles caused 2 million deaths and up to 60,000 cases of blindness annually worldwide. So it's a huge burden of disease. But they've made recent estimates over the past 15 years, and they see that measles vaccination has prevented 20.3 million deaths, which is huge. And measles, however, though, is still a cause of death among children, and 400 children die per day from measles infection. And as Louis said this morning, RSV, there's 300 deaths, but we have a very good vaccine, and this is still occurring, in the 21st century. The effectiveness of the vaccine is very good. One dose of a measles-containing vaccine is around 95% effective, and 2 doses are 97% effective. And the immunity from these vaccines is very good, whether you're vaccinated or also whether you get natural infection. And this is important because then it prevents reinfection. The timing of the measles vaccination can affect the effectiveness, and this is something that is very important. So you need to balance when an infant is at greatest risk versus when they are sufficiently immune, or when their sufficiently mature immune system can actually respond to the vaccine. And Iris will touch on this a bit in her study. But what I will just first show you is that we did a systematic review last year for the World Health Organization. And what they were looking at is the effect of giving the measles-containing vaccine below 9 months of age. So what we can see in this graph is that here is the immune response to the measles vaccine at 9 months of age, so it's somewhere around the 90 percentile. And then we get a higher proportion of response when it's above 11 months. And we can see that, with the increase in age, we see an increase in response to the vaccine. But again, you need to outweigh which is more important. The CDC did a study last year where they looked at the number or the age group most affected by measles worldwide, and they found that 11% of measles cases are occurring in infants below 12 months, and many of them are below 9 months. So what do? You have these infants are most susceptible for complications, high fatality rates. Do you just let them not have a vaccine because they're below 9 months, or do you give them some level of protection and then they'll get 2 subsequent doses following that? So these are things that need to be balanced, and then it also prevents ongoing transmission in the population. So the WHO recommends that the vaccine is given at 9 months where the risk of measles is high, and is recommended at 12 months where the risk of measles mortality is low. The second dose is recommended at 15 to 18 months in areas where there's ongoing measles, and in areas where there's very low measles transmission, then typically most European countries kind of decide when it's best for them to achieve the highest coverage, whether it's at school entry age or based on seroepidemiological studies. However, in light of the review that we did last year, the WHO actually has made a recommendation that during outbreak or travel to endemic areas that a measles-containing vaccine should be given at 6 months. And many countries had actually been doing this before, even though it is considered off-label use. But now that there is actually some form of documentation from the WHO, then people can feel a bit more confident. But it is something that will probably require further research. So if we look, this is the most recent report from the WHO looking at the number of measles cases with onset date between March and August of this year. We can see that it's widespread in every region, but particularly it's problematic in areas where there's low resource settings or high population densities. And if we look at the case distribution by month in WHO regions, we see that even over the past 4 years, there really is problems in certain areas, with most of the burden coming from the Western Pacific region, the Southeast Asia region, and also the Africas. So one of the things that you would think is, what is the coverage like in these countries? And we can see that in those areas where we see a lot of measles cases coming from, these are the areas that have low vaccine coverage, which makes sense. But again, it's problematic because many of these countries are low resource settings, and measles is kind of considered a canary in the mine type analogy, because it kind of is an indicator of how poor your health system is. So this kind of shows you that, not that we don't already know this, but it kind of gives you evidence of how poor the health systems are in place in these settings. If we look at Europe, this is from ECDC. This is giving us the coverage of 2 doses of measles-containing vaccine for cohorts 2013-14, or in between 2013 and 14, and the number of measles cases as of August 2016. You can see that many countries don't provide data. That's also problematic, because then you don't know. We can see that there is measles in quite a number of countries, and at the moment there's quite a large outbreak in Romania, which it's quite, I mean, I think there's been 1,000 cases reported up to now and 6 deaths. And they're trying to carry out large vaccination campaigns, but I think at the moment they've only vaccinated 3,000 children. So clearly there's problems there with vaccine coverage. But it just goes to show you that even in a region of Europe, we also are not doing so great either, with many not reaching the targets or providing data. Okay, so now we're going to go on to the definition of elimination versus eradication. So measles elimination is the interruption of measles transmission within a defined geographic region. So this is essentially what has been going on, or kind of one of the main aims of the WHO, is to firstly reach elimination. Eradication is a much, much bigger, I suppose, goal, and that is global interruption of measles transmission and represents successful elimination efforts in all countries. But recently, the US, or the Americans said that they had reached a measles eradication. Even the New England Journal of Medicine said that the US or the Americans had measles eradication. So clearly it's not something that people understand, that we haven't got there yet. And it probably will take, I think, quite a number of decades until we get there. But it is something that has been debated for a long time, whether measles eradication is something that could be done. And was first debated when the vaccine was first licensed in the 60s, and then it was following smallpox eradication in the 80s. And now that polio is now almost 99% eliminated, it kind of gives an opportunity to increase the efforts and kind of try and build on that to show that it actually can be done. So the criteria for eradication, there are 3 criteria. So humans are the sole pathogen reservoir. You must have accurate diagnostic tests and also an effective practical intervention that's available at a reasonable cost. I think it's safe to say that measles meets all those criteria. But eradication is the ultimate goal, and I think the WHO, if you just saw the spread of measles in all those regions, you can't just say in the next 10 years we're going to have measles eradication. It's the ultimate goal, but I think they're just a bit hesitant to say when they will try and accomplish that. But I think the first step is to start with elimination. And the criteria for elimination is quite strict, is that you need to have documentation of the interruption of endemic measles for at least 36 months from the last known endemic case. You also need to have presence of verification of standard surveillance and genotyping evidence that supports the interruption of endemic transmission. So these are quite strict criteria, and you can imagine that countries with low resources would not be able to fulfill these. So it just shows that more support is needed. Basically, what you need to do to eliminate measles, kind of the first step, is that countries should achieve 90% measles vaccine coverage in every district. So what we mean by every district is countries provide estimates where they say that they have 95% coverage, but they could have areas or pockets where they have much lower coverage than 95%. So that's why you need to try and understand that the population immunity needs to be slightly higher to prevent measles outbreaks. So I'm just going to run through the Global Measles and Rubella Strategic Plan. So the goal of this is to achieve measles and rubella elimination in at least 5 WHO regions by 2020 by implementation of 5 core strategies. So these 5 core strategies are to achieve and maintain high levels of population immunity by providing vaccination coverage with 2 doses of measles and rubella containing vaccines. They also want you to monitor disease using effective surveillance and evaluate programmatic efforts to ensure progress, as well as develop and maintain outbreak preparedness, respond rapidly to outbreaks and manage cases, and also communicate and engage to build public confidence and demand for immunization. The 5th one is to perform the research and development needed to support cost-effective operations and improve vaccination and diagnostic tools. So these strategies are very ambitious, but this is what they've set for the goal for 2020, and I suppose it's just a matter of time to see how well countries can adapt to some of these strategies. Some progress to date, so that they did a midterm review of these strategies recently, and it was presented at the Strategic Advisory Group for Immunizations, and they found that 139 of 194 countries or member states have included a second dose of measles-containing vaccine in their schedule. The remaining countries are very reliant on supplementary immunisation activities, so that is very costly. And however, the global coverage with MCV2 has risen from 48 to 61, so it's some improvement. But there have been an estimated 4.25 million deaths have been averted relative to no measles vaccination at all. So I think that that's an important action that has been showing progress in this. So in terms of successes by regions, by the end of 2015, 61 member states had received regional verification for elimination, and these were predominantly in the Americas and in Europe. So in the Americas, they were really quite ambitious in that they launched this initiative to eliminate measles in '94, and they really were very, very strict. If there's any importations, they really take this very seriously. And they essentially have eliminated measles by conducting a one-time national campaign to bring children between 1 and 14 years of age up to date with their measles vaccination. They also strengthened routine vaccination to reach a minimum of 95% of children every year, and they also undertook massive follow-up campaigns every 4 years to reach a minimum of 95% of children aged 1 to 4 with the second dose. If we look at the elimination efforts in Europe, we can see that things have been going where we're going quite well. We saw a 98% drop in cases between 93 and 2007. And since then, it's kind of been stable. I updated this for them, for the WHO Euro region, to show that in 2014, they had 20,000 cases, and then an increase in 2015 of 30,000 cases. And this was mostly from 4 countries, and also as a result of ongoing outbreaks in certain European countries, Bosnia and Germany. But you showed that there has been great progress, but then it is faltering a little bit, and it is problematic for Europe. They have set elimination targets on numerous occasions, but they've never been met to date. So the next one, the 2015 was not reached, so 2020 maybe. But however, in 2014, 32 of the 53 countries had interrupted transmission of endemic measles and or rubella in Europe. And this was achieved through high quality surveillance, monitoring chains of transmission, and very high immunisation coverage in those areas with 2 doses of a measles-containing vaccine. So some of the failures, it's been kind of difficult for some areas because progress kind of faltered between 2008 and 2010. And that was mostly from a certain number of areas. So Africa accounted for 36% of the measles mortality in 2010. And then in the Southeast Asian region, India accounted for 47% of the mortality in 2010. So you see that these 2 regions are accounting for vast majority of measles mortality. Then in Europe, we had a number of problems because of prolonged outbreaks, as I said, in also in Kyrgyzstan and Serbia. And then at the moment, then we have this outbreak ongoing in Romania that is problematic. So what are the global challenges for measles elimination? Well, the first thing is because it's so infectious. So that is hugely problematic, as it's very difficult. It's an ongoing chain of human to human transmission. So you have to try and ensure that you can try and get a certain level of coverage that will prevent that in the population. Also, the goals have not been fully implemented or appropriately adapted to local situations. So as I said, you can't say that the Americas achieved it and that Europe can, but I think they need to be more tailor specific. Because in certain areas there's civil conflict, they have weak health systems, there's insufficient resources, there's cultural barriers to reaching certain groups, as you can understand in the Netherlands. And also, there's also, I think, sometimes a lack of interest or concern about measles. People don't realise that it is a dangerous disease, that it can cause complications, that it can cause death. And most people think that it's a forgotten disease and that there's no need to worry about it. But I think it's a different story than if someone they know does get it and they have kind of severe complications. And then finally, there's a problem with inadequate monitoring and use of data for action. So in the DRC last year, there's a huge measles outbreak. Many people went in to try and supplement with supplementary immunization activities. But to try and get to the root of why there is kind of areas that are not vaccinated, there is more research needed. And it seems that some people just don't have the time or resources to do that. So if we forget about the global challenges, let's just think about the Netherlands. So the Netherlands has a high MMR coverage with 95 and 92% respectively for MMR 1 and 2. So that's very high. It has a strong health system, I think we would all agree. It has definitely sufficient resources, and it has adequate monitoring and use of data for action in many different ways in terms of surveillance, but also with the use of the vaccine registry. That really is something that you should be very glad you have. And it was used as an intervention for the outbreak in 2013 and 14. So you were able to target a population and offer immunization. However, the problem in the Netherlands is the cultural barriers to reaching certain groups. And that, of course, relates to the Orthodox Reformed Protestant community. So you have the Bible Belt, where you see that this is the area where we have kind of the lowest coverage of MMR. And this corresponds to the votership of the SKP. So this is what is happening. So Tom is going to discuss this when he talks about the outbreak that he investigated for the 2013 and 14. So I mentioned the midterm review that was conducted recently, and they made some recommendations based on this. What they recommended is that it might be better to actually check at school entry, which again is a little bit optimistic if you kind of assume that every child goes to school, but to check and could contribute greatly to strengthening overall immunization services. They also recommend that measles and rubella vaccination programs should be considered as an indicator of immunization program performance. So I think it's a very good recommendation. And focus on measles surveillance can help detect program weaknesses. And like I said, measles is considered the canary in the coal mine for detecting problems with immunization programs. So if you see recurrent measles outbreaks, you clearly have a population that is susceptible and that haven't been either targeted or missed opportunities for vaccination in the past. So I suppose many people, if they don't really have concern about measles, it's why do we want to eradicate measles? Well, it's highly infectious, it causes high morbidity. We have a very effective intervention available that's also cost effective. It's an indicator of your health system, so if you do have problems sometimes with recurrent outbreaks, aside from having groups that are opposed to vaccination, which is a whole other story, and probably something that is going to be problematic more and more in the future with people against vaccination. But outbreaks are also very costly. And Anita Suikerbeek, she looked at the cost of the outbreak in 2013 and 14, and it cost the Dutch $4.7 million. And then in the US, they did a modeling study where they looked at what the cost of unvaccinated adults are to the US economy, and that came to 7.1 billion. So you can see that vaccinating is cost effective. So, but again, it's just the attitude towards vaccination, I think, is probably it's going to become more behavioral studies as time goes on. So can it be done? And I think this depends on who you talk to. So you have skeptics, you have optimists, and you have realists. So I consider myself an optimist. And clearly some people also are, because based on the midterm review, they actually think that these goals can be reached. Whether they can be reached by 2020, I don't know, but they do require substantial escalation of political will and also investment. And also as many countries are very reliant on these supplementary immunization activities. And also people need to focus on improving ongoing immunization systems. I think that's a very important recommendation. Also, there needs to be an increased emphasis on surveillance so that, like I said, programmatic and strategic decisions can be guided by data. And that's critical because if you see outbreaks, you can intervene either by offering some form of catch-up campaign in the community or just trying to see if there is any problem issues, even with cold chain. And then outbreak preparedness and case management is important, as well as research and development. So these are kind of the optimist view of can it be done. But in conclusion, I think that, the measles vaccine is highly efficacious with durable immunity. Countries and regions that are aiming to eliminate measles and control rubella, need to improve and implement monitoring vaccination strategies. And really, from public health perspective, it is about the people, and the work that you do is important to build public trust. I think that's something that is going to have to continue if you want to try and get, people who may be hesitant about vaccination to try and take the time and actually listen to their concerns, and also to try and show that the demand for vaccination is important. I'd like to thank these were my measles supporters while I was in RIVM, so I'd like to thank everybody and thank you for your attention.